All right, let's dive right in. Today, we're tackling one of the biggest hurdles for anyone working in healthcare in the age of genomic medicine, and that is, how in the world do we make sense of genetic variants? It's a complex, often confusing landscape, and it's absolutely critical we get it right. So here's our game plan. We're going to start with just the sheer scale of the data problem we're facing. Then we'll look at the frameworks that have been built to try and manage it all. A big chunk of our time will be on the VUS challenge, that's variants of uncertain significance, before we get into communication strategies and finally some real-world practical guidance for your clinic. So how did we even get here? Well, it all comes down to next-generation sequencing, or NGS. I mean, it's an unbelievably powerful technology, but it's also created this absolute flood of information. And that, of course, creates its own unique set of problems.
And to really put that into perspective, check out this number. Every single person who has their genome sequenced is walking around with about 500,000 genetic variants where we just don't know what they mean. And with the cost of sequencing dropping like a rock, the number of patients with this kind of data is just exploding.
And this right here, this is the heart of the issue. NGS is a fantastic tool for finding things, but it doesn't come with an instruction manual. The overwhelming majority of the genetic alterations we uncover are of unknown clinical relevance. We find them, but we simply don't know what they mean for a patient's health. Okay, so to bring some kind of order to all this chaos, the medical community has developed some standardized frameworks. You can think of these as a shared language, a way to chart the waters of this data flood so we can all make rational, evidence-based decisions together. Now, there are two main systems you're probably going to run into. On one side, you've got the SCAT framework from the European Society for Medical Oncology. This one is all about actionability. It ranks variants in tiers based on whether there's a drug or therapy you can use. On the other side, you have the ACMG/AMP guidelines, which use a 5-class system from clearly disease-causing or pathogenic all the way down to benign. And right there, smack in the middle, is that tricky category, uncertain significance. And that middle category, the VUS, is really the core of this whole interpretation hurdle. It's this fog of uncertainty that can cloud our clinical judgment and, let's be honest, cause a ton of anxiety for absolutely everyone involved. So what exactly is a VUS? Well, it's pretty much what it sounds like. A lab has found a genetic variant, but there's either not enough evidence or the evidence we do have is conflicting. We just can't say for sure if it's harmless or harmful. It's the big, frustrating gray area of genetic testing. And for you as a clinician, a VUS result brings up so many tough questions. I mean, how do you explain this deep uncertainty to a patient without causing panic? The guidelines say a VUS shouldn't be used for clinical decisions, but that is much easier said than done. And what do you tell their family members? Then what happens when, maybe a year later, the lab sends you an email saying they've reclassified that variant? It's a lot to handle, especially for those of us who aren't trained geneticists. And you can only imagine what it's like for the patient. Getting a VUS result often leads to a whole lot of psychological distress, frustration, and just plain confusion. You know, they hear the name of a gene linked to a disease, they see the word variant, and their mind just jumps to the worst-case scenario. And studies show that anxiety can stick around for a year or even longer. And this misunderstanding can have severe real-world consequences. This quote here highlights the absolute most extreme examples, where VUS results in genes like BRCA were taken as pathogenic, leading to irreversible surgeries. This is exactly the kind of patient mismanagement we have to prevent. So that really brings us to the most important question of all, right? How do we as healthcare professionals navigate all of this uncertainty effectively, and how do we guide our patients through it safely? The number one most critical tool we have is communication. The way we frame and talk about these results can make all the difference. It can be the decider between a patient feeling informed and empowered versus feeling totally confused and anxious. But wow, it is not easy. I mean, look at this slide. It's pretty telling. In one study, even after expert genetic counselors carefully explained that a VUS result was uninformative, a staggering 79% of patients still walked away thinking it meant they had a genetic predisposition to cancer. That communication gap it's a huge hurdle. And this is exactly why the consensus best practice is so clear on this. Yes, VUS results should be disclosed to patients, but that disclosure absolutely must be bookended by expert pre- and post-test genetic counseling.
It's really the only effective safeguard against misinterpretation and mismanagement. Okay, so for this last section, let's pull out the compass. Let's talk about the practical steps and best practices for actually managing a VUS result when it lands on your desk.
The most important thing to remember is that a VUS isn't a permanent diagnosis. It's a temporary state based on what we know right now. The path to clarifying it or reclassifying it involves gathering evidence from a few different places. First, we check large population databases. Is this variant common in healthy people? Then we do a deep dive into the scientific literature. We also look for functional studies that actually test the variant's effect in a lab. And finally, we use computational or in silico tools that try to predict the variant's impact. And this is sort of what that whole process looks like in practice. This is an example of a clinical decision support tool. You can see how it pulls in all these different types of evidence: population frequency, functional studies. It weights each piece according to those ACMG/AMP guidelines, and then it computes a final classification. The literature search is a huge piece of the puzzle, and tools like this are just essential. They give you a curated bibliography for one specific variant, letting an expert quickly filter through everything and find the most relevant studies out there. And here's a peek at those in silico tools. What you're seeing is multiple predictive algorithms all run at once, and this dashboard gives you an integrated view. You can see at a glance if the different models are predicting the variant as damaging or deleterious, which provides another important layer of supporting evidence. Now, this is probably one of the most important slides for you and your patients to understand, and that's the direction that most of these reclassifications go. The data shows that the vast majority of VUS, we're talking about 90%, are eventually downgraded to benign or likely benign. Only a small fraction, around 7.5%, actually get upgraded to pathogenic. That context is absolutely crucial for managing a patient's anxiety. So, let's wrap this all up with the key takeaways for your practice. First, use your multidisciplinary teams like molecular tumor boards for these complex cases. Second, you have to commit to ongoing education. This field changes constantly. Third, know the reclassification policy of the specific lab you're using. And finally, and this is probably the most important one, make sure your patients have a clear and easy path to an expert genetic counselor. We'll end with a little thought for the future. As our data sets grow from millions of genomes to billions, and as AI gets smarter and smarter at spotting patterns, is it possible that the variant of uncertain significance will one day just become a historical curiosity? It's a fascinating question as we keep mapping the human genome. Thanks for joining me.